Hyperthyroidism is an overactive thyroid disease. Like hypothyroidism, it's also divided into either overt or subclinical hyperthyroidism. Subclinical hyperthyroidism is more common, affecting 0.7 to 1.8%, and is defined as a low TSH with normal free T4. In overt hyperthyroidism, TSH levels are also low, but free T4 is elevated. There are various causes that can result in increased levels of thyroid hormone in the body. The most common cause of hyperthyroidism is Graves' disease, which is an autoimmune condition that increases the production of thyroid hormones and increases thyroid gland growth. Graves is most common in women and those under the age of 40. Hyperthyroidism can also be caused by non-cancerous nodules, such as those found in toxic adenomas or toxic multinodular goiters, pituitary adenomas, pregnancy, postpartum thyroiditis, or various medications. Those include amiodarone, lithium, interferon alpha, and interleukin 2. Like hypothyroidism, subclinical hyperthyroidism is usually asymptomatic. However, overt hyperthyroidism may also present with few symptoms, but can be life-threatening, as is the case with a thyroid storm. If symptoms are present, they may include weight loss, diarrhea, muscle weakness, tachycardia, anxiety, depression, insomnia, and dysphagia, which is difficulty swallowing. Thyroid storm can occur following abrupt cessation of anti-thyroid medication, infections, or following radioiodine treatment. The greater the number of symptoms, the greater the likelihood of thyroid storm occurring. Prompt referral is needed to prevent morbidity and mortality related to a thyroid storm, which can result in arrhythmias, cardiac failure, seizures, and coma. During physical exam, a tender thyroid can indicate subacute thyroiditis, which develops following viral infection and has been associated with echovirus, influenza, Coxsackie virus, and mumps. A thyroid adenoma presents as a single nodule on palpation, whereas someone with multinodular goiter presents with multiple nodules. Anyone presenting with a thyroid nodule should receive serum testing and be referred for a thyroid ultrasound to rule out cancer, as 5% of nodules are due to thyroid cancer. The treatment goal is to reduce the level of thyroid hormones produced in the body and to reduce overall symptoms. Untreated hyperthyroidism leads to weight loss, osteoporosis, atrial fibrillation, and embolism, but rarely with cardiac failure. Treatment will depend on the underlying cause of hyperthyroidism. To treat Graves' disease in non-pregnant women, medications include PTU, MMI, surgery, or radioablation. PTU and MMI inhibit the production of both T3 and T4, but through alternate pathways. Relapse can occur, and individuals with a history of Graves' disease should be screened regularly in clinic. Surgery should be reserved for severe cases or for those in which medications are not possible or have been ineffective. Subacute and postpartum thyroiditis generally resolve over time. Therefore, treatment includes only supportive measures to treat those symptoms. Postpartum thyroiditis is the most common cause of hyperthyroidism after childbirth. It's an autoimmune condition that is triggered by immune changes during pregnancy. Postpartum thyroiditis is most common in women with other autoimmune diseases and those with elevated TPO antibodies. TPO stands for thyroid peroxidase, which is an enzyme normally found in the thyroid gland and plays an important role in the production of thyroid hormones. Therefore, the presence of TPO antibodies suggests an autoimmune thyroid condition, such as Graves' disease or Hashimoto's. Postpartum thyroiditis presents initially with hyperthyroidism, followed by a period of hypothyroidism, and then resolves within the first postpartum year. Postpartum thyroiditis is not generally treated, as thyroid hormones fluctuate greatly and generally self-resolves within 1 year. Women should be followed closely during this time with thyroid function tests drawn every 4 to 8 weeks, the first year postpartum, and then annually. Advanced practice providers should consult with an endocrinologist.